Thank you so much for joining us today. It's right at the top of the hour. And I want to thank you because I know this has been a very hectic month for primary care providers. And your lunch hour is really important. And the fact that you're sharing it with us to really remind yourself or learn for the first time about ways to screen for autism is very noble, and I want to thank you for doing that. We are awarding an hour of CME credit at the end. You'll get information about that. Hopefully that's a little bit of the sting of your lunch hour. We also have a chat box open for questions all through the training today, and we will have time at the end to get to that. We also want to share with you a new resource that maybe you're not aware of that allows you to put in your patient's zip codes and find all the local resources, including diagnostic assessments that are close to your patients based on their zip codes with anything related to autism. So we want to make sure we share that with you as well. I do have a little disclaimer or disclosure. I set the bar high for doing trainings. I spent 10 years as a primary care pediatrician in the Army before going into developmental pediatrics. And every training that I attend and every training that I offer has to reach the bar of would I have given up one of my lunch hours to get this training. So I hope the perspective is worthwhile to you as well. This is the gobbledygook for the CME. You don't need this slide. I will say that funding for my time and some of the work that we're doing is based on a HRSA grant that is directed by Dr. Micah Mazurek, and I am the co-director. It's called the Virginia Links Grant. It's a state autism implementation grant that has been running for the last 2 years, and we still have 2 more years. And part of this grant is to support 4 regions in Virginia, underserved regions in Virginia, Southwest Virginia, the Lynchburg area, Orange Culpeper, and the Shenandoah Valley, towards improving the lives of children with autism and their families. And we are working with a very committed group of interdisciplinary community providers, such as the Southwest Virginia Links work group listed here. And it was actually their impetus that got us started on this training when they asked for MCHAT training in the Southwest region for some of their providers. And so I want to give a shout out to this group, along with the larger virtual learning community who meets once a month on the second Tuesdays. And if you're interested in that, let us know in the chat box. Also, I will mention that the CME is paid for off of this grant so that we can offer it to you free. So the objectives today, it's fairly brief, is to learn to administer and score the MCHAT revised with follow-up interview, a screening tool for 16 to 30-month-old children in primary care practices. The current recommendations from the American Academy of Pediatrics includes routine screening with an MCHAT R at 18 and 24-month well child visits, and anytime a parent has concern, at least up to the age of 3. Then I want to share with you how to communicate the findings of a score, which is often difficult, and know what your next steps are and resources in your local area when I share with you our autism drive and how you can look for where's the best place for this child to go if they need further diagnostic assessment. So autism spectrum disorders are a complex and heterogeneous neurodevelopmental disability with an estimated prevalence of 1 in 54 children. Boys are identified about 3 times more frequently than girls. And although this diagnosis can become stable, in early toddlerhood, the average age of diagnosis in the United States is after 4 years of age. So autism spectrum disorders are currently diagnosed under the Diagnostic and Statistical Manual number 5. It's a term that describes a constellation of early appearing social communication and interaction deficits, as well as restrictive, repetitive interests and sensory motor behaviors that are atypical for development and get in the way of typical development. These are the core, this is how I describe it, the core symptoms of autism, and they can occur with or without intellectual disability and with or without language delay. So you don't have to have global developmental delays or language delays to have autism spectrum disorders, the core features. Now, many of us finished our training before 2013, some many years before 2013, which is when the Diagnostic and Statistical Manual number 5 really came up with a much more revolutionary evidence-based paradigm for the diagnosis of autism. So for those of you who want a quick review, I picked out 2 review articles, one by Catherine Lord that's in the Lancet from 2018, and another one by Corey Schulman from 2020. And the nice thing about the 2020 article, which is a review, is that it's across the lifespan. So it even talks about autism in adulthood, and we've learned a lot about that in the last decade. So the Centers for Disease Control has been tracking the prevalence of autism since 1996, beginning with children in the metropolitan Atlanta, Georgia area. Subsequently, the CDC established the Autism and Developmental Disabilities Monitoring Network, or ADDM, which has reported autism prevalence in multiple communities across the US in even number years since 2000. And it's from this in the last 20 years that we see the prevalence of autism being reported through this mechanism has increased 175%. So the most recent data that we have is reported in 2020 about the prevalence in 2016, because it takes a few years to get all of the data in. And this is for children who carry a diagnosis of autism at the age of 8. So I just wanted to share with you why there's such a need for developmental screening. One of the things that people wonder is, like, when do signs of autism first present? And this is relevant to when we offer our screening tool. In fact, 30 to 54% of parents register their first concerns before 12 months. And I often see children referred to me, and it's about the 9-month well child visit where the parent and the primary care provider order a hearing screen because the parent perceives that the child isn't hearing them. And that may be the first clue of an autism spectrum disorder. But 80 to 90% of parents recognize child abnormalities by 24 months of age. There continues to be a significant lag between the first concern and an autism diagnosis. And one thing is that we as providers, we often give false reassurance if we see the child frantically looking at us, making eye contact, or describing that it's the terrible twos. But In one study, the majority of caregivers of children who were later diagnosed with autism indicated that they perceived that their child's primary care provider did not act early enough on their developmental concerns. The single most distinguishing characteristic of very young children who have autism, part of that core feature is a deficit in joint attention, which is manifested as deficits in social reciprocity and interaction. Typically, joint attention rolls out spontaneously when a child looks back and forth between an interesting object or event and the caregiver to share their interests. Often these typically developing 8 to 10-month-olds will start to follow a parent's gaze to another object or seek out eye contact. That's when we see peekaboo emerge. At 10 to 12 months, the child begins responding to following a point, following somebody else directing their attention. And very soon thereafter, they start to direct attention. So they'll start initiating a point to something that they want. And then by 14 to 18 months, they will start pointing out something to not just to show a request, but merely for the fact of showing somebody something interesting in their world. That proto-declarative pointing, when absent, is almost pathognomonic for a child with autism of any cognitive level. So this is proto-declarative pointing. These, my adult children were 17 months and almost 3 when a helicopter hovered over our house many, many years ago. And you can see the 17-year-old not pointing to name it, not pointing to request it, but pointing it out to show it to me. So it's, I'm looking at something interesting. Do you see what I'm looking that's interesting? It's a helicopter. I'm looking at this helicopter. So it's that triadic gaze that is typically developing at 18 months that is absent in children with autism. I've spent a little time on this joint attention because this is what, these are the features that the MCHAT asks about to inform us about what a child does at home for the parent. So joint attention, the absence of joint attention is a red flag for autism. Calling another person's attention to an object, gaze monitoring, bringing to show, pointing out just to show, if absent, a very early robust clue of autism. Likewise, symbolic play starts out as simple play when miniature toys are used for their intended purposes, like pretending to have a tea party or talking on the phone, which occurs at around 15 or 16 months of age. And this becomes more complex when you can even see somebody using a pen or a stick as a telephone. And then from there, at 2 years of age, is this blossoming of imaginative pretend play. Most children with autism are not as interested in toys for the sake of playing with them, except for the way that they look at them or perhaps understand a part, like spinning the wheel. A little 20-month-old that I saw recently holds a piece of paper in his outstretched hands and then kind of twirls in circles and then watches the paper drop, and then he picks it up and he watches the paper drop. So asking at 18 and 24 months, what's your child's favorite toy, most favorite? What's their manner of play? How long can he or she play with alone before seeking the attention of someone else? Now, in developmental clinics, you see these big boxes of toys that look very expensive, but I'm going to tell you that many toys are our hands. So playing peekaboo, playing patty cake, playing itsy bitsy spider, and even rolling up a piece of the exam paper and tossing it back and forth for turn taking are all very inexpensive and informative ways that we can interact with a child at the ages of 18 and 24 months. So I want to move to the modified checklist for autism in toddlers revised with a follow-up. This is a free screening tool that many of you are already using. It's developed for children 16 to 30 months, but I use it even older than that, especially if a child is nonverbal. It's well validated in large samples. You can see here that it takes about 2 minutes for a parent or caregiver to complete, and a completely negative screen where the pattern is 0 fails looks like this. It looks like all yeses except for number 2, 5, and 12, which the correct answer is no. A positive screen would be when somebody fails items and they get a point for each of those failed items, and we'll talk about that. One of the things that comes up that is beneficial about this revised is if you notice at the bottom, there are only 20 questions, and this one was devised in 2009, and it's attached to improved questions from the older MCHAT that had 23 questions and developed in 1999. So if you have the old one, rip it up and download this free new one. We're going to give you lots of opportunities to see that website. And it has better questions. They got rid of a couple questions, and then it has a stage 2 that's needed for about 5% of your population. At the MCHAT Screen website, where a ton of this is all easily downloadable, you can make a laminated copy of the screener scoring. So any answer that falls outside of the box, the blue boxes, would get a point. And that would be an easy way for someone in your office to score the MCHAT that a family has already taken. So then the question is how to interpret the MCHAT scores. So a total score of 2 or less fails anywhere along the MCHAT is low risk or green zone, and no further follow-up is recommended unless they're going to get a 24-month MCHAT because they just had one at 18 months. So in a way, that's your pass. And 93% of children fall in this category. At the other end, in the red zone, or a positive screener, is if you add up points outside of the correct answers and you have greater than or equal to 8, you don't need to do anything else but start them on the path for referral. And about 1% of children fall in this category. So the only place where about 5 to 6% of children land is if they have 3 to 7 fails. And this is where the screener has been improved with regards to its sensitivity and specificity by adding stage 2 follow-up interview. So to decrease the false positive rate. So the follow-up interview is also on the website. Here's an example. It's an algorithmic approach. Say if the child missed number 17, stage 2 involves pre-scripted questions for the initial item. So the initial item was, does Manny try to get you to watch him? You answered no to this question. That's what made it fall outside of a correct answer. Is that right? And the parent would say, that's right, I answered no. Then you're given multiple other choices to kind of get that same feel of getting a child trying to draw attention to himself or herself. And if the parent answers, well, yes, my child does one of these other 4 things, then that fail score from the initial screener turns into a pass score. If they still have 2 or more fails or incorrect answers in the follow-up interview, that moves them to the red zone for further evaluation. So here's the example. If it's less than or equal to 2, they pass. There's nothing more to do. If it's greater than or equal to 8, they fail, or it's a positive screen and you need to refer. And if it's 3 to 7, you need to find those questions that they failed and ask a few follow-up questions. And if they still fail after some follow-up questions in 2 or more of the questions, then you need to move them into the red zone. So we're gonna practice this with a patient. I borrowed this slide from my colleague, Wendy Stone, out at the University of Washington, where she summarized a lot of the tests, the screening test statistics for the MCHAT R. But use of the follow-up interview is critical for reducing false positives when there's only 3 to 7 fails that occur in the original screen. And when you get all your kids either in the green zone or the red zone, a positive screen is 114 times more likely than a negative screen to find a child who's going to be subsequently diagnosed with autism. So it's worth it. And 95% of children with a positive screen, while some of those children won't have autism, they have other developmental delays that are worthy of the actions that you are taking. So it's a win-win. Many of you might know Paul Carbone. He's a general pediatrician in the Midwest. He also has a son with autism, and he recently published in Pediatrics kind of the real world use of the MCHAT R across a large system of care. And what he found was that primary care providers are more likely to administer the MCHAT at the 24-month visit rather than the 18-month. And I know all the reasons for that, but both are recommended. And if you can identify someone at 18 months, you've got a 6-month leap on interventions and supports. He also said we need to pay closer attention to our underserved populations, that if the family where English is not a primary language, we really don't have an excuse to not give the MCHAT in their primary language. The MCHAT Screen website has at least 30 other languages that have been translated. Also, PCPs are unlikely to perform the follow-up interview. And refer the patients that screen in the yellow zone as if they were red zone. Unfortunately, this could cause undue distress to the family. It definitely causes undue distress to people like me who are seeing kids who maybe would have otherwise passed. And it increases the wait time for children who had true positive screens. Understandably, the follow-up interview takes a little bit of extra time. It could be done in a follow-up visit, or it could be taught to an office staff member who could do it over the phone. When explaining the results to parents, I think it's important to take a deep breath and pause. One parent said, "You will never forget the first words the doctor spoke to you telling you there was a problem with your child." So I think this 3 steps is a very good strategy for explaining the results, any result, but definitely a positive MCHAT screen result. Give a brief description of the screener, discuss the results that were specific to this child, and then suggest next steps and hope. So you might say, one of the screening tools we routinely provide in my practice is the MCHAT R. It contains questions about social communication and development of your child. It identifies risk for developmental delay and autism. Your responses suggest that Manny isn't showing some social communication behaviors expected for his age, such as, and then you might comment on the positive screen. Is this consistent with what you observe at home? This doesn't mean that Manny has developmental delay or autism, but it does mean that we need to take a closer look at these behaviors. I'd like you to contact your local early intervention infant toddler connection so we can take a closer look. Then let's set up another appointment to talk a little more, and I will work with you to get Manny the help he needs. So here's a case, and we are going to, I'm going to read through this, and then we're going to score together an MCHAT. This is, Manny comes for his 18-month well child visit. As you enter the room, you smile at Manny. He is engaged in trying to open a fruit snack pack and does not look up. You ask his caregivers how he's doing, and they say, great. He loves to explore our apartment and laughs like crazy when we play peekaboo. We have started taking him to the park and he enjoys playing with blocks. Manny has said very few words during the assessment. His eye contact is variable. When you ask about his use of language, Manny's caregivers indicate they have noticed he's not saying as many words as they had anticipated at this age. They attribute this to him being raised in a bilingual household, being the first child, and having a shy temperament. They indicate he usually says, uh-oh. So you administer the MCHAT. Here is Manny's MCHAT. Please score it, and you can put in the chat box what you think the score is. Remember, number 2, 5, and 12 is a pass, is negative if no is the answer. I see some answers coming in. I made it hard, I'm not gonna lie. Okay. So I'm getting some of the right answers, but I'm also getting some that maybe aren't capturing every single incorrect answer. So if you look at this number, remember, everything should be yes, except for 2, 5, and 12. So that's why the laminate helps. Just put it over there and count the ones outside the box. So if you see number 1, the parent answered no, that is incorrect. So they get a point. Number 2, they answered no, but that's correct. Number 3 and 4 are yes, and that is correct. Number 5 is no, and that is correct. Number 6 is yes, and that is correct. However, number 7, they answered no, and it should be yes all the way down to number 11. Number 12 should be no, but they answered yes. Number 13, 14, and 15 are correctly in the yes category, but number 16 and 19 were answered no, and everything from 13 to 20 should be yes. So you should have 5 incorrect scores. With 5, that puts you in that category of an intermediate fail. So you haven't really gotten to a green zone or a red zone. You're gonna have to ask a few interview questions to put yourself more confidently in a positive screen versus negative screen. So remember, if it was less than or equal to 2 fails, so you can fail on 1 or 2 things, it counts as a pass and you move on. If it was greater than 8, you move on to a referral and other actions that you can take. But this was 5. So we need to do stage 2 follow-up interview. The questions that were missed were 1, 7, 12, 16, and 19. Here's an example of the pre-scripted algorithm for number 1. And what it does is it asks, is that right? Did we understand this correctly? Then it gives you some other options for pass examples and fail examples. And it has you move down through the algorithm to kind of what does the child do most of the time? And most often what happens when you do the second part interview for these 5%, 5 out of 100 MCHATs, when you do that, you move from a fail initially to a pass, from a fail to a pass. So Manny, when I asked all of these questions, he ended up moving from a fail to a pass on number 1, 16, and 17, but he remained a fail on number 7 and 12. So if you look on the follow-up interview, if you fail 2 or more, that more confidently puts you into the red zone, or it's time to do more work. It doesn't allow you to pass. So if you have a concern for autism after an MCHAT, you don't have to make a diagnosis to act. You just need to explain that we need to take a closer look. One of the best ways to take a closer look, especially for a child under 3, is the statewide free program that's Infant Toddler Connection. And those can be looked up based on the location where you are in the state. Something extra, a safety net that Virginia has through the public school system, is that for children over the age of 2, they can be referred to the local school for an early childhood special education assessment if for some reason Infant Toddler Connection isn't available or there's a problem, etc. So there is some overlap between the ages of 2 and 3. You can also do a medical speech language pathology evaluation to get some speech language pathology started. You can check not just for the newborn screen for hearing, but for a second screener of some kind. And then refer for a formal developmental and autism evaluation. Now, this is where a wait list often emerges. We're trying to get better at the children under the age of 4 and making sure that the wait list is less than 3 months, but we're still not there, especially after this last year. But one of the things we're going to show you today is how to look for the closest diagnostic tool to where your patient lives using the Autism Drive. And then I recommend that you follow up with these children in 2 to 4 weeks just to find out what the parent has been able to accomplish. You can code the 96110 for this screener. So success in the clinic, what I wanted to say is as part of the grant that we've been doing since 2019, we have had cohorts of primary care providers who meet twice a month and become champions of children who may have autism. And I'm going to share with you that in just a second. But what we found is most of them have said it was easiest to print out hard copies and attach it to the 18 and 24-month well child visits for the parent to complete while waiting for the visit. Alternatively, it could be emailed to the family and they could complete it and you could have them score it while you see them in telehealth. Finally, some people use a laminated MCHAT so that it can be washed off with cleansing solution after a visit. Definitely, most of the primary care providers found it easier to administer when someone in their support staff learned how to score it, and perform the follow-up interview by telephone if needed. Also, they found it easiest if they anticipated a positive screen. So to create a parent handout or an electronic health record phrase when there is a concern, so that you can just go over that with them rather than trying to remember it all yourselves. So I just wanted to share with you, currently our Virginia Links primary care provider autism course is full, but we have another one starting in March. It's free, and you get a ton of CME, MOC4, MOC2 points. And it is a small group of collaborative learners get together virtually over lunch, and we discuss cases and we do didactics twice a month to learn to recognize and respond to the needs of children with or at risk for autism spectrum disorder. So if that's something you would like to do, why don't you go ahead and get your name on the wait list now by putting it in the chat box that you're interested, and we'll get back in touch with you. Also, but wait, there's more. The knives commercial. Right now, Paul Carbone and others are offering some modules free if you're a member of the AAP. So Identifying and Caring for Children with Autism Spectrum, a course for pediatric clinicians. You can register, you can get regular CME for this. If you just go into the PediaLink or the Shop AAP website. I do think you have to be a member. I'm not positive, so you can try it out if you're not and see, but you just register and then it comes up as free, and you take these 6 modules whenever it's convenient. So that's another thing that you might be interested in. I think it's good until April of 2023. Just FYI. So we're going to be emailing you how to claim your credit for today's visit. This is what the email will look like. You go to a CME Village website and you put in an activity code. Most of us are pretty familiar with this, and it will let you print out your certificate.